A doctor prescribes the same drug dose to two patients. Patient 1 takes it at 8 in the morning. By 9 a.m., the pain is completely gone. Patient 2 takes the exact same dose. By noon, it's a deadly overdose. What do you think really happened? Welcome to episode 1 of DLS, Bright Life Scientists. Today we are covering Introduction to Pharmacology and Routes of Drug Administration. By the end of this video, and I want you to take this off as we go, you'll be able to 1. Define pharmacology and explain its major branches. 2. Classify all routes of drug administration with examples. 3. Explain the advantages and disadvantages of each route. 4. Identify which drugs are given by which specific routes and why. And 5. Apply all of this to clinical and exam-style questions. Take a screenshot of this slide. We'll come back to this at the end. Let us begin. So, what exactly is pharmacology? The word itself comes from Greek, pharmakon, meaning drug, and logos, meaning study. Pharmakon meaning drug and logos meaning study. So put them together and you get pharmacology, the science that deals with drugs and how they interact with living systems. At the heart of pharmacology is understanding the nature of drugs, where they come from, what they do, and how the body handles them. Now, pharmacology has two major pillars. And if you only remember two things from this entire series, make it these two pillars. Pillar 1, pharmacodynamics. What is pharmacodynamics? Pharmacodynamics is what the drug does to the body. Think of receptors, mechanism of actions, how the drug acts on the patient. Pillar 2, pharmacokinetics. And pharmacokinetics is what the body does to the drug. It's just the opposite of pharmacodynamics. Pharmacokinetics is what the body does to the drug. Here we think of how the body absorbs the drug, distributes the drug, breaks it down, and eliminates it. Here, we always use the mnemonic known as ADME, ADME. And here is your golden rule. Screenshot this. PK, which is pharmacokinetics, body on drug. PD, which is pharmacodynamics, drug on body. Now, food for thought. Think about this while we continue. If PK is what the body does to the drug, and a patient has a liver failure, what happens? The liver cannot metabolize the drug properly. The drug accumulates, and now even a standard dose produces toxic and dangerous effects. Same dose, completely different outcome. That is the pharmacokinetics at work. And it is the answer to our opening question, which we'll come back to. Well, pharmacology is a broad science. It has several branches, and these appear on practically every pharmacology exam. Screenshot this slide and save it. You will thank yourself later. Pharmacokinetics, we said it's what the body does to the drug, ADME, absorption, distribution, metabolism, and elimination. Pharmacodynamics is what the drug does to the body, mechanism and effect. Pharmacotherapeutics, this is the clinical use of drugs in the prevention and treatment of diseases. This is the practical application of pharmacology. Then chemotherapy, the use of drugs to treat infections, cancers, and parasites. Then toxicology, the study of harmful effects and poisoning caused by drugs and chemicals. And pharmacogenetics. Pharmacogenetics is one of the most exciting modern branches of pharmacology. It studies how your genetic makeup affects how you respond to drugs. This is why the same drug works differently in different people. All of these branches connect to each other, and by the end of this series, you'll understand all of them. Now, routes of drug administration. This is the question every medical student must be able to answer cold. How do we get a drug into the body? And why does the route we choose matter so much? All routes fall into major categories. First, we have local routes. Local routes are where the drug is applied directly at the site where it needs to work. the drug stays local. It doesn't move elsewhere. It stays local. Think of topical creams on the skin, intra-articular injections into a joint, intrathecal injections into the spinal cord. Second, systemic routes. Here, the drug enters the bloodstream and is carried throughout the entire body. Systemic routes are divided into two groups: enteral, which means through the gut, and parenteral, which means bypassing the gut. Enteral routes: oral, which is tablets and capsules, swallowed by mouth, and rectal, which is suppositories. Parenteral routes, and this is where it gets rich, include intravenous, IV, intramuscular, IM, subcutaneous, intradermal, transdermal patches, sublingual, inhalation, and nasal. We will go through each one in detail, but first, let us understand the enteral routes. Enteral routes. Let us start with the one you know best, oral route. The oral route is the most commonly used route worldwide. Why? Because it is safe, economical, and patients can take it themselves. No clinician needed. However, it has a critical weakness: fast pass metabolism. When you swallow a drug, it is absorbed from the gut into the portal circulation, which takes it straight to the liver before it ever reaches the rest of the body. The liver metabolizes a large portion of the drug right there. Some drugs lose so much that they become almost useless by mouth. Classic examples of drugs with high fast metabolism include nitrates, lignocaine, propranolol, pethidine, hydrocortisone. Learn that list. It appears on exams constantly. Rectal route. Now, the rectal route, this is not just for suppositories in embarrassing situations. It is a genuinely important clinical route. The rectal route avoids fast pass metabolism to about 50%. Why only 50%? Because the rectal veins drain partially into the portal vein and partially into the systemic circulation directly. It is useful when the patient is vomiting, unconscious, or cannot swallow. It can be used in emergencies, and it is particularly useful in children. Classic example: diazepam given rectally to children during febrile seizures. Why rectally? Because the child is convulsing, they cannot swallow, and you need the drug to work fast. The rectal route delivers it softly. That clinical scenario, diazepam, rectal, febrile seizure, children, is an exam favorite. Do not forget it. Now we move into the parenteral routes. These are routes that bypass the gastrointestinal tract completely. We start with the injectable parenteral routes, and there are 4 of them: IV, IM, subcutaneous, and intradermal. IV, which is intravenous, this is given straight into the vein, and this is the king of all routes because bioavailability is 100% guaranteed. Because the drug goes directly into the bloodstream, there is no absorption step needed, no fast pass, nothing. Onset of action is fastest in IV. It's used in emergencies, for example, in cardiac arrest, severe sepsis, status epilepticus. However, and this is critical, once you give an IV drug, you cannot take it back. If you give the wrong dose, you cannot recall it. This is why IV medications require extreme precision. Now we go to intramuscular route, IM. Intramuscular, it's given straight into the muscle. The needle goes in at 90 degrees, perpendicular to the skin, deep into the muscle belly. Bioavailability is 75 to 90%. Absorption is slower than IV, but faster than oral. Examples: streptomycin, vaccines, certain antibiotics are given using this route. Then subcutaneous route. Subcutaneous, it's given into the layer of fat below the skin. The needle is always placed at an angle of 45 degrees. The great advantage here is self-administration. Patients can do this at home. Classic example, it's in insulin. Every diabetic patient on insulin is giving themselves subcutaneous injections, also heparin and growth hormone. Now we go to intradermal route, ID.
Intradermal, it's given into the dermis, the most superficial of all injections. The needle angle is 10 to 15 degrees, almost flat against the skin. And here is the key examination point. A bleb must form, a visible raised bump under the skin. If no bleb forms, the injection was not truly intradermal. Examples: BCG vaccination and allergy skin testing. Golden rule for your exams: IV is always 100% bioavailability. Intradermal requires a bleb. Write those down. Now, the non-injectable parenteral routes. These bypass the gut without using a needle. They are elegant, patient-friendly, and very clinically important. Now, we start with the transdermal route. Through the skin via a patch. Only drugs that are highly lipid soluble can be absorbed this way. The beauty of transdermal delivery is constant, controlled release. The drug is delivered at a steady rate, meaning blood levels stay stable, and you do not need to dose as frequently. Examples: nitroglycerin patches for angina, nicotine patches for smoking cessation, fentanyl patches for chronic pain, and hyoscine for motion sickness. Then we have the sublingual route. Sublingual is placed under the tongue. This is one of the smartest routes in pharmacology. The drug is placed under the tongue and absorbed directly into the systemic circulation through the sublingual veins, completely bypassing the liver. First-pass metabolism is avoided entirely in this sublingual route. The onset of drug action is rapid. The patient can do it themselves, and if needed, before full absorption, they can spit out the rest to stop the effect. Classic example, we have nitroglycerin for acute angina. A patient gets chest pain, they place a nitroglycerin tablet under their tongue. Within minutes, relief ensues. Try giving it orally, 90% destroyed before it works. That is why sublingual wins in this case. Then we have inhalational route. Inhalational, the drug is breathed through the lungs. This is unique because the rate of drug delivery can be controlled precisely, almost like an infusion, intravenous injection. You control the concentration of what the patient breathes. You control how much of the drug enters the bloodstream. Examples: salbutamol and ipratropium for asthma, inhalational anesthetic agents like nitrous oxide, and inhaled steroids. Then we have the nasal route. Nasal, the drug is delivered through the nasal mucosa, can produce either local or systemic effects. Drugs given nasally include nafarelin, which is a gonadotrophin releasing hormone agonist, calcitonin for osteoporosis, and desmopressin for diabetes insipidus. All of these bypass first-pass metabolism by entering the systemic circulation directly through the nasal mucosa. All right, stop. Write your answers down. Do not scroll ahead. Pause the video if you need to. Question 1. A patient with severe chest pain is given nitroglycerin. Why is it given sublingually instead of orally? We have option A, sublingual route has 100% bioavailability. Option B, it avoids first-pass metabolism and that's faster. Option C, it is easier to swallow sublingually. D, oral nitroglycerin causes more side effects. Write down your answer for question 1, then continue. Question 2, which injection angle is correct for an intradermal route? We have A, we have option B, we have option C, we have option D. Write your answer. We will reveal both answers later in this episode. Pause the video if you need more time. Think carefully. When you are ready, continue. Let us talk about topical absorption, and specifically something that surprises most students when they first encounter it. Absorption from topical route is inversely proportional to skin thickness. In other words, the thinner the skin, the more drug gets absorbed. Looking at absorption gradient across different body sites, the posterior auricular region, just behind the ear, has the highest absorption. Thin skin, rich blood supply. Next, we have the scrotal skin, also extremely thin and highly permeable. Then the scalp, then the dorsum of the hand, and finally, the plantar area. The sole of the foot. It is thick, keratinized skin and usually has the lowest absorption. Here is your food for thought, and this one always gets a reaction. Testosterone patches are sometimes placed on the scrotal skin specifically because of this principle. The scrotal skin absorbs drugs up to 40 times more than the sole of the foot. 40 times, yes, 40 times. Same drug, same patch, completely different blood level depending on where you put it. This is why route of administration and site of administration both matter enormously in pharmacology. Now remember our opening question. Why does the same drug work differently for the two patients? The drug works perfectly for one patient but causes a deadly overdose in another. Now that we understand pharmacokinetics and routes of administration, we can answer this precisely. Reason 1, different routes create different bioavailability. If one patient receives nitroglycerin intravenously and another takes it orally, same dose on paper, but the IV patient gets 100% into their bloodstream, while the oral patient gets almost nothing because of fast pass metabolism. Widely different blood levels, completely different effects. Reason 2, fast pass metabolism varies enormously between individuals. Genetic differences in liver enzymes mean some people metabolize drugs 10 times faster than others. A dose that is therapeutic in one person might be subtherapeutic in a submetabolizer or toxic in a slow metabolizer. Reason 3, pharmacokinetics, absorption, distribution, metabolism, and excretion all vary per patient. Age, weight, kidney function, liver function, genetics, other medications, all of these alter how a drug behaves. Same dose does not mean same blood concentration, and same blood concentration does not always mean the same effect. This is why pharmacology is not just about drugs. It is about drugs in the context of individual patients. All right, let us reveal the answers. How did you do? Question 1, the answer is B. It avoids fast pass metabolism and acts faster. Why? The reason for this, nitroglycerin undergoes more than 90% fast pass destruction when taken orally. 90%, yes. That means less than 10% of what you swallow ever reaches the bloodstream. It is essentially useless by mouth for acute angina. Sublingual nitroglycerin bypasses the liver entirely. The drug goes directly into the systemic circulation through the sublingual vein. Result, rapid relief within minutes. And just to be clear, option A is wrong because sublingual route does not have 100% bioavailability. That is the IV route. Question 2, the answer is C, 10 to 15 degrees. Intradermal injection goes almost flat against the skin, 10 to 15 degrees. The needle barely penetrates. Just into the dermis, a bleb must form, a visible raised bump, no bleb. It was not intradermal. Option A, 90 degrees, is intramuscular. Option B, 45 degrees, is subcutaneous. Memorize those angles. Before we go to our fact frog and the mnemonic, here are our short answer and long answer questions for this episode. Short answer question, a patient requires urgent pain relief but is vomiting and cannot swallow. List 2 appropriate routes of drug administration with one drug example in each case. Short answer question 2, explain why the oral route is not suitable for propranolol in some patients. What pharmacokinetic process is responsible? And your long answer question, compare and contrast all routes of drug administration with the reference to bioavailability, onset of action, advantages, disadvantages, and clinical examples. Write your attempts in the comments below. The answers will be fully revealed at the start of episode 2. Comment your answers, even if you're not sure. That is how learning happens. And before we get to our memory trick, Fact Frog has something to tell you. Did you know the scrotal skin absorbs drugs up to 40 times more than the sole of the foot? 40 times more. Yes. This is why testosterone patches are sometimes placed specifically on scrotal skin. Thin, highly permeable, maximum absorption. One patch in the right location delivers as much drug as 40 patches on the sole of the foot. And Fact Frog's bonus fact for today, the intravenous route is the only route with guaranteed 100% bioavailability. Every other route loses some drug through fast pass metabolism, incomplete absorption, tissue binding. This is why in the ICU, almost every critical drug is given intravenously. Precision is everything when a patient's life is at stake. Now, the BLS memory trick, and this one you'll never forget once you see it, to remember all the non-oral parenteral routes, we use the mnemonic tips rise. All the non-oral parenteral routes, we use tips rise, whereby T stands for transdermal, through the skin. I is for inhalational, breathe into the lung. P is for parenteral injectable, where we have IV, IM, subcutaneous, and ID. There are 4 actually in this P. And S is for sublingual, under the tongue. R is for rectal, suppositories. I is for intradermal, into the dermis. Blood must form. S is for subcutaneous, under the skin, 45 degrees. E is for enteral, oral route, through the gut. Screenshot this slide right now. This is your episode 1 revision card. Let us run through quickly everything we covered today. Pharmacology is the study of drugs, built on 2 pillars: pharmacokinetics, how the body acts on drug, and pharmacodynamics, how the drugs act on the body. Pharmacokinetics is the ADME process: absorption, distribution, metabolism, and excretion. Routes divide into local, where we have topical, intra-articular, intrathecal, and systemic. Where we have enteral in systemic, oral has high fast pass metabolism, and rectal avoids 50% of it. Injectable parenteral, IV, 100%. IM is injected at 90 degrees angle. Subcutaneous injected at 45 degrees. We said for subcutaneous, it can be self-administered. Then for intradermal, 10 to 15 degrees, and a bleb must form. For non-injectable, we have transdermal, inhalational, we have sublingual and nasal, which all bypass the liver. Then skin absorption, we said posterior auricular is the highest, plantar is the lowest, and your mnemonic tips rise locks it all in. You have covered episode 1. Well done. That is everything for episode 1 of BLS Bright Life Scientist. If this helped you understand pharmacology even a little bit better, then we are doing exactly what we set out to do. 3 things before you go. 1. Subscribe and hit the bell icon. Episode 2 drops next week. Pharmacokinetics. Part 1 will be about absorption and bioavailability. It builds directly on everything you learned today. You do not want to miss it. 2. Comment your answers to the SAQs and long answer questions below. Try them even if you're not sure. We read every single comment and we will verify your answers at the start of episode 2. 3. Share this video with one friend, one classmate, and one colleague who is also studying pharmacology. You never know whose exam you might just save. Until next week, keep studying, keep asking questions, and keep pushing forwards. Illuminate, educate, inspire. I will see you in episode 2.